I'm Dr. DEEPTI and I'm going to speak on undiagnosed traumatic frontal encephalocele presenting with superior field defect. I have no financial interest. Orbital roof fractures are a rare entity. Traumatic encephaloceles in the orbital cavity are very, very rare, and up to today, only 15 cases have been reported worldwide. The most important cause is blunt trauma by direct or lateral blow to the orbital rim. Delayed diagnosis of this rare entity can lead to various neuro-ophthalmic complications, which I will discuss later. So, a 24-year-old boy presented to our OPD with complaints of unable to see the top part of the right eye. His best corrected visual acuity was 20/20 N6 in both eyes. Anterior segment evaluation was unremarkable. Pupils were bilaterally equal and reactive. He had normal color vision. IOP was 14 mm Hg in both eyes. Fundus examination revealed a temporal pallor in right eye. Left eye, the fundus was normal. When we took the history, he had a history of motorbike accident 3 months ago, where he had a head injury on right side. Since he was treated elsewhere, he had an uneventful recovery following a short stay at the hospital. OCT macula both eyes were normal. OCT ONH in right eye showed inferior and nasal quadrants thinning. In left eye, the OCT ONH was normal. When we did the field with CETA standard 30-2 with Humphrey field analyzer, it showed a complete superior hemifield defect with VFI of 56%. In left eye, the fields were normal. This was a time when we again reviewed our radiological examination, which to our utter surprise revealed a fracture of the right frontal sinus with focal herniation of the brain parenchymal tissue. Coronal and axial scan further revealed the formation of encephalocele. Thus, the diagnosis of post-traumatic frontal encephalocele was established. Patient was then referred to neurosurgical department for management of any complication. Coming to encephalocele is defined as an extracranial herniation of the brain parenchyma through a defect in the bony skull. Mostly it is congenital, and the ones which are acquired mostly are traumatic, and very few cases are idiopathic or secondary to tumor. This is a very rare entity, and the diagnosis is often delayed due to the ecchymosis and the swollen eyelids, and often the patient is generally obtunded when he presents to the hospital. Gerard had classified it according to the anatomy into occipital, head dome, frontoethmoidal, also known as sincipital, and basal encephalocele. Based on the amount and the location of herniation, the symptoms of frontoethmoidal encephalocele may vary from rhinorrhea, recurrent bacterial meningitis, proptosis, and visual field defects. Coming to the uniqueness of the case, as I have told earlier, only 15 cases of traumatic orbital encephalocele has been reported. This was an index case where we had a traumatic frontal encephalocele presenting with only field defect. Here the field defect was only monocular, hence the lesion was prechiasmal. The herniation was very subtle, impinging upon the inferior optic nerve fibers, thus causing the superior field defect. This case was peculiarly interesting because an eye finding led to the diagnosis of previously missed neurosurgical finding. Thus, the management of this case was a combined effort of both ophthalmological as well as of the neurosurgical team of our hospital. Kullu and al. Had reported in 2015 a traumatic frontoethmoidal encephalocele that they had presented with CSF leak. The main complication to look out in orbital encephalocele is optic nerve compression, which can be either directly due to the pressure effect or due to the raised intraorbital pressure causing secondary congestion of draining veins, including retinal veins, leading to its atrophy and hence vision loss. Fortunately, in my case, the defect was very minimal. So, by the consultation with neurosurgical team, a conservative approach was used. Had the pathology had been stubborn or progressive, more invasive procedure have been required. In larger defect, there is evacuation of herniated brain through frontal basal approach, and defect is closed by either temporalis fossa, titanium mesh, bone powder, fibrin glue. Then, coming to the case, we are continuously under follow-up and observation to see any progression of the fracture. And the neurosurgical team is also observing. So both the teams are continuously observing the case. But nevertheless, one persistent problem with the patient was that he has a hemianopia. So we have to manage the hemianopia. So due to the propensity of the patient to develop accidents and collisions, we counsel the patient to avoid driving. One more persistent problem with hemianopic patient is what is known as hemianopic dyslexia. That is, according to the type of hemianopia, whether superior, inferior, or nasal or temporal, the patients have the problem of scanning lines. So we gave him a trial of yoked prism, which he had a good acceptance, which artificially brings the visual environment that falls into the blind field into the patient's seeing field. So concluding, in this era of ever increasing road traffic accidents, facial trauma of variable severity is frequently encountered. Traumatic frontoencephalocele encephalocele, though a rare entity, should always be kept in mind in these patients. What is most important is proper examination at both at the time of presentation and also after in the subsequent follow-ups, because early diagnosis is necessary to prevent the development of potentially life-threatening complications such as meningitis. These are my references. Thank you.
Would you like to recommend anything based on this case for early diagnosis? For example, what nature of injury, what kind of injury, what profile of patient would you subject to imaging as a first line of investigation?
Sir, first the main mode of diagnosis is the CT scan, which gives us the encephalocele. In complex encephalocele, even MRI is also recommended. At the time of...
This was accidentally discovered because of the visual field defect.
Yes, yeah.
But given the number of accidents that are increasing, the last slide you have mentioned.
Yes, sir.
So which patient would you like to have a CT scan on day one?
So those who are predominantly who are having facial injury, because mostly in the orbital rim we have to examine it for any defect. Then we can go for a CT scan. Mostly facial injury.
Any other symptoms the patient had?
No, sir. That is a peculiarity of the case. Only he had field defect. And
no findings at all?
No. So he didn't even have RAPD, and there was only temporal pallor in right eye.
Temporal pallor.
Because the field, but fortunately for the patient, the encephalocele was very subtle. So that is why neurosurgical team said that they won't operate it. They won't reduce the encephalocele. That is why we went ahead and only did management of his hemianopia. That was his present complaint.
No signs of congestion also?
No, sir. He had presented to us 3 months after the accident. 3 months before he had gone somewhere else. That is why it was missed.